Hello everyone and welcome to another session of Next Saviours Essential Question Series. Today we are going to have a discussion on a important topic, that is fractures around the proximal femur, and what are the basic differences in between the two and how ultimately you have to conclude to the answer related to the question. So basically it is the fracture neck of femur versus the intertrochanteric fracture in the proximal aspect of the femur, which are very common in clinical practice. You see, understanding the pathophysiological mechanism behind these two, or the identification on the x-rays, that fracture neck of femur is obviously in the neck and the neck region is lying inside the capsule. So whatever the complications and related to the complications, the management strategies, these are all dictated because of this anatomical perspective of this fracture neck of femur, that it is lying inside the capsule. On the other hand, the intertrochanteric means in between the two trochanters. That means lesser trochanter and greater trochanter. If there is a fracture happening at this site, intertrochanteric region, then it will be called as intertrochanteric fracture. Now, intertrochanteric fracture is extracapsular, and based on this anatomical perspective, it is going to be presenting with the different complications. Now, let us start with the clinical presentation. Now, imagine in your emergency on the couch, the patient comes. So, how will you decide that on the basis of the clinical presentation only that the fracture could be intertrochanteric or fracture neck of femur? So, you see, both these two fractures will be presenting with the shortening and external rotation of the limb. But because the fracture neck of femur is intracapsular, so inside the capsule, if there is a fracture, then it limits the proximal migration of the distal end of the femur. As a result of which, although there will be shortening, but it will be lesser in case of fracture neck of femur. While in case of intertrochanteric fractures, because it is lying extracapsularly, so there will be too much of the proximal migration of the greater trochanter in comparison to fracture neck of femur. So shortening in both of them, but greater shortening in case of IT fractures and lesser shortening in case of fracture neck of femur. Second is that when the patient is lying supine on couch, then normal external rotation is around 10 degree, but the affected external rotation will be almost up to 90 degree in case of IT fractures. While in case of fracture neck of femur, it will be externally rotated, but might be lesser in comparison to the IT fractures, because again, the capsule, it prevents the complete external rotation in case of fracture neck of femur. So in fracture neck of femur, although there is shortening and external rotation, but these are lesser in comparison to the IT fractures, where the shortening as well as external rotation will be more. You see, if a question is presented to you like a 72-year-old male came to the emergency after getting slipped in the washroom, he was not able to bear weight on the right lower limb, and when he was presented to the couch, or when he was lying down on the couch, then the lateral border of the right foot was touching the couch. What does it mean? External rotation all the way up to 90 degree. So this is the feature of intertrochanteric fracture, and this is how you will identify it clinically. Rest of the things are going to be determined on the X-ray findings. Next, ecchymosis or the swelling. You see, in case of fracture neck of femur, again, because they are intracapsularly lying fractures, so lesser ecchymosis and lesser swelling. While in case of IT fracture, there will be more ecchymosis and there will be more swelling. Why? Because these are extracapsular fracture, there will be more bleeding, there will be more tissue edema. So only this is how the clinical features are going to be identified. The rest of the things you already are aware of, like both these two fractures are the fractures of the elderly, and fracture neck of femur tend to happen more in case of osteoporotic bones. Next are the complications. You see, the first point that we have discussed are the clinical presentation. Second is the complication, before even talking about the management, because management is defined actually by the prognosis of the complications. That means how this fracture will be proceeding in future, or how the fracture is expected to behave in future. On that, the management is decided. So what are the complications in fracture neck of femur? Now try to understand that if this is the neck, GT, LT, it is lying inside the capsule, and if there is a fracture over here. Now, because of this fracture, after 8 years of age, the head of the femur is supplied by the retinacular vessels only. And this fracture, if it is displaced, then it might result in the injury, direct injury to the retinacular vessels also. So there will be a associated injury to retinacular vessels. And one point which is very clearly identified, that this fracture head of the femur is having a precarious vascularity. That means lesser vascularity in comparison to the other regions of the bones. So if this retinacular vessel, which is the sole supply to the head of the femur, is also injured, then it might result in avascularity to the head of the femur, and that will result in the complication. Another complication is that if there is a fracture in the neck of femur, then obviously there will be collection of the blood inside the capsule, which will raise the intracapsular and subsequently intraosseous pressure. So there will be raised intraosseous pressure. Now, if this raised intraosseous pressure is responsible for compressing the end capillaries, then it might also predispose the head of the femur to go into osteonecrosis or avascular necrosis. Thirdly, inside the capsule, inside this capsular fluid, there is a provision of the enzyme by the nature, and the enzyme is hyaluronidase. And you know what is the function of this enzyme? The function is to break the clot, to break the hematoma. And you know, the first stage in the fracture healing is the clot formation or the hematoma formation. So imagine if the nature has provided a sort of an enzyme which is responsible for interfering right at the first stage of the fracture healing, then it also predisposes to avascular necrosis and non-union. And that is the reason why the most important complications over which entire management of that patient would be decided are the osteonecrosis, head of the femur, and non-union. Now it becomes much easier for us to understand that how the management is being decided. For example, a 60-year-old patient comes to you, okay, and he is having a fractured neck of femur, and what you did is CCS fixation. That means you fixed the fracture by the application of the cannulated cancellous screws. Okay, the fixation looks good. Over a period of time, there is a possibility that it might go into non-union or avascular necrosis. So subsequently, what you did after several duration of time, what you did was get the x-rays done because the patient came with the complaint of persistent limping and increasing pain. Now here what you see is that the x-rays of the head of the femur looks sclerotic, the head of the femur looks flattened, and the head of the femur seems to be laterally deviated. Now, all these features are suggestive of the development of the osteonecrosis, that means avascular necrosis. And this is the reason why now you might have been thinking that instead of fixing the head of the femur, I should have gone with the replacement of the head of the femur, because ultimately now you have to proceed with the replacement. And this is the reason why the complications, the possible prognosis, it determines the management protocol. It defines the management protocol. So what are the possible management in fracture neck of femur? One, obviously, that we have seen that cannulated cancellous screws of 6.5 to 7 mm are placed or directed in order to achieve the fixation. But you know, the possibility of avascular necrosis and non-union, it remains in the head of the femur. So very lucky the patients are that if they unite without any complication. Okay, that is point number one. Another point is why to go for fixation? Why not to remove this head of the femur? Because you know, I feel like the chances of union are too less in this case, or the chances of avascular necrosis are too high. Then in that case, you remove the head of the femur and the fractured neck, and instead you provide a artificial implant inside this. You give the internal prosthesis without anything placed onto the acetabulum. So this procedure is known by the name of hemiarthroplasty. Hemi means half. Arthroplasty means reconstruction of the joint. So that means you are reconstructing half of the joint. You are removing just the head and neck, and you are placing the artificial head and neck with a stem which is placed inside the intramedullary shaft of the femur. You are not doing anything to the acetabulum. Acetabulum of the patient would be utilized for the purpose of bearing counterweight from this implant. So that is why hemiarthroplasty. So what is the advantage of hemiarthroplasty in this case? Like, the patient is able to bear weight right from the next day after performing surgery, because you have removed the head, you have placed the artificial head, and now you can ask the patient to walk immediately after surgery, the next day after surgery usually. While in case of CCS, obviously, you have to make the patient bedridden for a certain duration of time, and once you feel that the patient can bear weight, maybe after 1.5 months, maybe after 2 months, maybe after 3 months, then you will ask the patient to bear weight. So obviously, when the patient is of older age group, like 60 years, 65 years, 55 years, where the fracture neck of femur are more common, then in that case, instead of going up with the fixation, you can go with the replacement, because it decreases the possibility of secondary complications related to the fixation devices. But in case the child is young, in case the patient is extremely young, then obviously you have to take a chance in order to save the natural head. Then fixation is justified. Now, in those cases where the patient is young and the head of the fracture is having a very high possibility to go into complications, like if I say it is a subcapital fracture, that means just at the base of the head of the femur. If I say it is garden type 4 fractures, if I say it is Powell angle more than 70 degrees, that means greater the angle, that means the fracture angle is more than 70, then obviously it would be having a poorer prognosis. Now in those cases, instead of going with the fixation, you have to come up with the articulation of both head as well as the acetabulum, and that is achieved by total hip replacement. So total hip replacement is one another option for the management of fracture neck of femur, which would be having a greater, yeah, that means better compliance, because here you are creating a articular surface which fits exactly with the head that you are placing inside. And obviously it will be having lesser complication in the sense of pain, in the sense of stability, in the sense of mobility. So these are the three options for the fracture neck of femur. In the nutshell, majority of the times the questions are going to be asked for the purpose of the identification of the implant. It is highly unlikely all the way that the examiner will ask you that what will you do. But imagine if they ask that what will you do, then they will give you a age of more than 60, because here you will be clear in your thoughts that I will go with the hemiarthroplasty. In case of younger individuals, obviously you have to go for attempting the fixation devices. Second point is, what is the type of the fracture? If it is basi cervical, where the chances of non-union are lesser, then you can go with the fixation. But if it is subcapital or transcervical, then the chances of non-union are too high. Then obviously the first priority would be to uh, to remove the head and neck of the femur and go with the hemiarthroplasty. Next are the complications of the intertrochanteric fractures. Now, in case of fracture neck of femur, we have seen that the non-union and the osteonecrosis head of the femur were the complications. But here in the intertrochanteric fractures, the fracture which is lying in between the lesser trochanter and greater trochanter, here the fracture is affecting the cancellous region, where the vascularity is too high and the chances of non-union are too low, because even if the fracture is not completely reduced, even if the fracture is maltreated or ill-treated or neglected, then also the fracture tends to unite because of greater surface area and increased vascularity. So if at all the intertrochanteric fractures have to go into a complication, then that complication is malunion. And what malunion usually results in, you see, in this case, ideally it should have been like this, where the GT should be lower, and this is how the neck shaft angle is preserved. But here in this case, what has happened, that the fracture, although united, but it has resulted in the varus deformity because of the proximal migration of the greater trochanter, where there is a reduction in the neck shaft angle. So this is how the complicated IT fracture looks like, where there is a malunion as a common complication. Malunion. You see, what were the complications in fracture neck of femur? It was non-union and osteonecrosis. Here it is malunion, which is a common complication in case of IT fractures. Then what is the management? Obviously, you just have to reduce the fracture. In the most apt position, most probable position, you have to reduce the fracture. And how is it achieved? By closed reduction internal fixation. And that closed reduction internal fixation can be achieved by two sort of implants. One is extramedullary implant, which is DHS, dynamic hip screw. Now this is the dynamic hip screw, and this is the DHS barrel plate. So you can achieve fixation by this. But what is the complication which is associated with this DHS implant? The complication is that that the force which is transmitted to the head of the femur, the lever arm becomes longer, as a result of which the force which is getting concentrated at this fulcrum, and then it is shared to the load bearing device. It is not a load sharing device. Remember, it is extramedullary implant, which is a load bearing device. So whatever the force which is getting transmitted all the way up to the DHS or the dynamic hip screw plate, this force is greater or larger, and that might result in the breakage of this implant at this fulcrum, at this junction, resulting into the implant failure. In order to combat this sort of a complication, there is another implant which came into existence for the management of the IT fractures, where the this lever arm length is shortened by the placement of these screws, cephalic screws into the head, thereby reducing the lever arm length by the placement of the implant which is there inside the medulla. That means intramedullary implant. How will you identify this implant? There will be an intramedullary implant with the cephalic screw. The name of the implant is the proximal femoral nail, PFN. So this is how the possibility of implant failure are to some extent reduced. But practically the complication exists in both these two cases. That means fixation with the DHS or with the PFN. Ideally, it's not like that you all have to go with the PFN for the management of the or for the fixation of the IT fractures. You see, make a simple criteria that if the patient is thin built and the fracture is uncomplicated in the sense that it is a simple fracture without too much of the comminution, then go with the DHS. But if the patient is obese or if the patient is having a complicated fracture in the sense that there is a posterior medial comminution, then you have to go with the proximal femoral nail. As far as this NEET PG examinations are concerned, you are asked in this stage about the identification of the implant, that how these implants looks like. So how will you identify a DHS? There will be a presence of a lag screw. This is the lag screw, and there is a barrel plate which is extramedularly fixed. What about this screw, this proximal one? It is the anti-rotation screw. This one, it is the anti-rotation screw, and it is not necessarily required for the fixation. Okay, it is just or based on the preference of the surgeon who is performing this management. Next, what are the complications? As I told you, the complications which might happen in case of DHS, that there could be a possibility of implant failure, because when there is too much of the force which is exerted at this junction, then it might result in the lateral breakdown of the cortex. That means there will be a lateral breach of the cortex by the DHS implant directly. So this is one possibility, which is one complication related to the dynamic hip screw. Now, what as a complication can happen in case of PFN? That the distal screw, if moves medially, that means the distal cephalic screw, if moves more medially into the acetabulum or into the hip joint, then this is known as Z effect. While if the proximal screw moves medially, this is the proximal screw which moves medially, then this is known as reverse Z effect. And this obviously is because of the differences in the force which is applied. And in order to limit these reverse or the Z effect as a complication, you have to choose correct size of the screws. The screws on the distal part should be larger, longer, and it should be thicker as compared to the proximal screw, which should be smaller in comparison to the distal screw. So these are the possible complications related to this. So hope you have understood that how the differences in between the fracture neck of femur and the intertrochanteric fractures are identified. Quick revision is that the fracture neck of femur is intracapsular fracture having a precarious vascularity, where extracapsular fractures are IT fractures which is having abundant vascularity. The clinical features, both of them are presenting with increased age group, shortening as well as lateral rotation, but this shortening and lateral rotation along with the ecchymosis and swelling will be more in case of IT fractures compared to fracture neck of femur. The fracture neck of femur is presenting with the complications of non-union and osteonecrosis, while IT fracture is presenting with the complication of malunion. The management of the fracture neck of femur can be achieved by CCS, the cannulated cancellous screws, by hemiarthroplasty, or by total hip replacement. We already have talked about that what are the indications which are based upon the preference of the surgeon by the calculation of the prognostic criteria. While in case of IT fractures, the management is achieved by the fixation devices. One is the dynamic hip screw, along with the complications we have talked about, and the other one is the proximal femoral nail, along with the advantages and the possible complications we have talked about. So hope you would be able to mark every answer correctly based on the identification of the implants or the clinical features. All the best for your future examinations. Thank you very much for listening to the lecture. In case not to miss any update, please join our Telegram group. The link is provided to you in the description.